broadcast on Facebook. So if you want to go to Afro-PHC on Facebook, you should find that as well. So welcome. Thanks for Professor Laurel Baldwin-Ragavan from the Department of Family Medicine and the Department of Health. She is basically coordinating clinically the family medicine departments across Southern Gauteng in the Department of Health at Gauteng provincial level. Welcome, Laurel.
Thank you very much, Shabir, and good morning, guests and colleagues. I can't see you, so I'm not sure who's there. Neither probably can you see me. So,
would you like to put your video on, Laurel?
I can do that, and then can people? Let's just see what my options are. Yeah, start video, and then there we go. Okay, good morning, everyone. Yep. I can see you, Shabir, but not everybody else. So.
Yeah, no, that's a problem. But you can proceed, and I think if we can have the conversation, and I think people who would like to ask questions, please feel free to add your questions to the Q&A, and then if need be, if you want to pick up your hand and discuss something, you can raise your hand, and we can take it on, allow you to speak. So that should be fairly interactive. Thank you, Laurel. You can proceed.
You're welcome. Okay, so I'm here actually very delighted to be here, really motivated by questions from you. When Dr. Torluter invited me to come, she said, you know, really people are wondering, what is this command center? And what are you doing up there? And so I've tried to frame the presentation to respond very specifically to the questions and concerns that you have. And I'll hopefully, we have 1 hour, Shabir, correct?
Yes, 1 hour.
Right. So there'll probably be about 15, 20 minutes of slides, and then we can leave the rest of the time for robust engagement. So I thought that I would start with a kind of history and context for what this war room or nerve center or command center is about. What is the current work that it's engaged in, and specifically, what am I kind of doing there? And then some personal reflections, and then we can have a discussion and dialogue. And because I wanted this to be very solution focused, you know, what resolutions have we come to? What is going to be the future work? And how can we formalize exchanges between the ground and the coalface where all of you guys are, and what's happening kind of up there? So the place to start is actually not with the command center. The place to start is with the MEC's Clinical Governance Advisory Committee. So last year in 2019, the MEC, the new MEC, wanted to formalize his relationship with clinicians. So via the MEC, via the HOD, that's Professor Maklukere, he established this Gauteng Clinical Governance Subcommittee. And essentially what it is, and I'll come to the specific specialties, but the MEC took these clusters, and the clusters are very central hospital focused. And in the reformulation, I insisted actually that the districts be there too, even though we are part of the clusters. But all of these central hospitals have university affiliations. So it's essentially the academic and clinical training platform for all of the specialties in that Gauteng trains. And there are representatives. So you have the hospital clusters, but you also have what's called the clinical cluster. So in fact, there is the surgical clinical cluster across all of these central hospitals. There's the pediatric clinical cluster, and there's the family medicine clinical cluster as well. And the representation then is a representative from any one of these 4 central hospitals, or in our case, the district health system, sitting on this clinical governance advisory committee. So there are actually 15 representatives, and I'm not going to go through all of them here. I suggested that we add oral health. There was also a suggestion from other colleagues that we have a representative from one of the, so the deans of one of the 3 medical schools in the province be represented. There's public health medicine, and I'll come back to this. It is important to sort of keep these specialties in mind, because this is what the representatives here are actually being called upon to give clinical governance advice and clinical input into the decisions around COVID-19 and the provincial response. Okay, is that clear? I hope so. Okay, so what's the mandate of this committee? So we actually clarified our mandate in February of 2020. And we are meant to provide an independent role, expert advice and guidance, and we make recommendations to the minister and the committee, the EMC Tech, for its consideration and final approval. However, we do not assume the functions of senior management in the department, and I think that's really important. So we really are providing guidance and recommendations and advice, but ultimately it's up to senior management whether they, whether they heed that advice and what they do with it. So these are sort of the, this responsibilities, basically unpacks that a bit more, and looking at sustainability on the clinical service platform, standardization, safety, and then we lastly we were supposed to be assisting the transitioning to NHI, to the implementation of NHI. So this was February, and by March, COVID hit. And the province was asked to provide, so this is now a provincial slide. This is no more the Department of Health. This comes out of the Premier's office. And Gauteng was mobilized into the entire apparatus, government apparatus was mobilized to provide an appropriate response to COVID-19. So what you'll see here is that there are these 6 pillars around the response, only one of which is health. And the others are around social services, so social grants, and I'll come back to that because I realize there's an issue with that, and food security, so the social determinants, also the kind of human solidarity. This is, this is really about communications and getting people to buy into the National Disaster Act. You've got law enforcement and compliance when they don't. This was also seen by the Gauteng Premier to, in fact, look at the resilience of government, and could they actually respond and adapt, and what kind of long-term changes could be put into place that would endure beyond COVID-19. And I think this is really important in health, because some of the things, or the majority of things that people are looking at, they're asking the question, so how can this improve our service delivery and our capacity beyond COVID-19? Then there's an economic response, and then finally this comprehensive health response, which I'll talk about. However, it is interlinked. It's not just spokes coming off a wheel. There should be actually, some kind of interaction around that. So it looks a little bit like the biopsychosocial model in a way, but yeah, it's our COVID-19. So what does the health response look like? So there are actually kind of 2 governance processes. One, and I'll come back to this because of the recent Premier's declaration of the hotspot in the West Rand was actually not according to this governance structure. So in fact, the Provincial Command Center, and as I said, it can be known as the War Room, the Nerve Center, but we're going to call it the Command Center for today. It actually is a branch of the National Command Center. And then you have the political oversight, and then you have a secretariat or the strategic administrative support. Then there are actually two team leaders. It's Arnold Malotana, who is the CEO. And I think it's important to realize that people have been deployed to support the command center from their various normal day jobs. And so very few people are, well, I guess they are still doing their day job, but the majority of their focus is in the command center. So it's Mr. Malotana and Dr. Nkwabe, who are the two team leaders. Then there's a secretariat. And then it's interesting because the public health people come in here. So there's a whole team of public health medicine specialists who are both on the Clinical Governance Advisory Committee, but they've also been brought in separately from Charlotte Macheke, Steve Biko, and to some degree in the districts to support the response. Then you'll have these, we have these 8 different work streams, and I'll come back to the work stream, but there's been someone assigned to each of these 8 different work streams. So this is just the official kind of without the reporting. So that's what I said. So this is essentially, this slide is here because you'll see that at the top of this is actually the National Command Center. So this is the provincial reporting to national. But the other line of reporting, kind of the dual appointment and dual responsibility, is the political oversight. So this is the premier. So in some ways, the organogram or oversight structure is also to the premier's office. And then the rest of it is the same. And I think it's clearer in terms of the work streams here that there's the contact tracing and management. There's the clinical work stream, which is hospital preparedness, essentially the hospital services, although the district health services fall in between both of these. There's the communications, the comms work stream. There's the occupational health and safety. This is where PPE comes in. The logistics with Mr. Khati, this comes in, he's normally head of EMS. Probably, I should probably just tell you what these people do in real life, but at any rate, so he deals with all of the quarantine facilities. He's head of EMS normally, so EMS is still within his purview. The mortuaries, so that's around logistics, transport, etc. HR, it's actually Ms. Bagoshi now from Charlotte who's taken over that work stream. The finance and the scenarios committee, this is very important because the finance is being leaked to the scenarios situation, and then you have research and M&E that's ongoing of this whole process. So there's a kind of reflective piece built into this. I put this up not so much to look at screening, but you're probably wondering, like, where do the districts fit in with this? So the districts, in fact, are there. You would know in the absence of all of your chief directors that they're actually in the war room. So every chief director is there, and they are busy feeding in the information that you provide to them on the ground into discussions and deliberations in the war room. So most of their day, and I'll go through the typical day because I really want to demystify this. They participate in the morning meetings, and then the rest of it is trying to ascertain what's the situation on the ground. So when I get told about tents, or when I get told about absence of swabs, these are things that should be still fed in via your own command structures in the district, ultimately to your chief director. So in fact, what I'm doing is bypassing this process and escalating, but your chief directors are still your chief directors, and there needs to be a mechanism to communicate with them because Maisie Larutla is coordinating them. As you know, she is the usual chief director. And so those things need to come into the war room via that communications channel. I'm happy to be here as a kind of backup when that doesn't work, but technically, you know, that's how that's supposed to feed in. So they're capturing data around all of the screening and all of the activities, in fact, that you're doing. Not only COVID-19 related, but they're also supposed to be feeding in numbers and activities, say, around family planning, antenatal, et cetera. You'll notice that correctional services is here with the districts, and they, for the purposes of COVID-19, they have in fact named correctional services across the province as a 6th district. I just want to kind of highlight that. I don't want to necessarily go into that unless people have questions, but they're counting that out of all the facilities across all of the districts. The governance for that is actually directly through Salamina, Dr. Salamina Shlaflane, and she is now the head of that district. So who else is there besides the heads and the kind of technocrats, as they like to call themselves? There are also representatives from WHO Africa, from the CDC African branch, the private hospital sector. So there are, Life and Netcare and MediClinic are all represented, and the other smaller ones are represented by one representative. The Premier's office is also there, correctional services, as I mentioned. So not just Salamina, but actual health staff from correctional services there. Medical director is present. And then we have guests. So guests come in to give presentations. Tom Boyles has been there, Yanni Hugo has been there, different representatives from employee wellness, social development, security, police. Yeah, they all come in and provide inputs and things for consideration. So how does it actually work? What happens? So at the moment, now that I'm with you, they would have started their morning briefing. And this goes on from 8 o'clock in the morning till about 10:30, sometimes later, 7 days a week. There is a standing agenda, but as I mentioned, there are also special things that special invitations that are given. And in the morning briefing, there's reflections on the past day. It usually, the day starts with a prayer from one of the long-standing colleagues, and problems are discussed, solutions proposed, and also, for example, on a particular day, on Wednesday, the public health group, which I've joined in some way. I should also say, I suppose, where I fit in across the work streams, but, you know, basically, you know, as the representative, as one of the two representatives or three representatives from the MEC's Clinical Governance Advisory Committee, it's myself, Prof. Basu, and Prof. Malaudzi, who's the chair of the Clinical Governance Advisory Committee. We fit ourselves in, and depending on the priorities that have been identified in the morning briefing, we look at that. On Wednesdays, as I mentioned, the public health medicine specialists and myself sit down and we analyze kind of what's happened in the last week, and we try to put together a narrative with you know, with suggestions about where people need to focus their energies. Sorry, let me just put this on silent. Bear with me. Okay. Then after that morning briefing is finished, everyone breaks away into these work streams. So the groups meet, and as I mentioned, there may be special projects or a special focus or an urgency, and this goes on till about 3 o'clock. So you can have one long meeting, 3-4 small meetings. You know, it depends where, you know, the urgency is for that day. And then that information at 3 o'clock feeds back into the Premier's 6 pillars. So the Premier then meets for the next 2 hours or so And then with those representatives from the 6 pillars, so in our case, the HOD is there, the MEC is there, as well as the head of the war room, Mr. Malotana, and Dr. Nkwabe. After that, we get a briefing, an evening briefing, where they come back and talk to us about what's happening in the command center. So this is kind of the day-to-day work that happens in the command center. And depending on this, there can be meetings after that, something that needs to happen very quickly, et cetera. So what are the kinds of issues and projects? I mean, I sat for maybe 10 minutes and just brainstormed this. There's more. I can go through all of them very quickly. We've dealt a lot with the HR issues, the recruitment. Most recently, I've been tasked with developing an orientation program, an induction program for the 28 Cuban colleagues who have come through. Testing has been something very big and contentious, and I've engaged with some of you, with many of you perhaps, on this issue. Determining the difference between what is isolation, what is quarantine, you know, do we have enough of these sites? Where are these sites? What's provided and who looks after them? What is a hotspot? And how do we conduct surveillance? And again, that's kind of linked with testing, but also exploring new ways, like can we do sewerage or stool analysis, especially in places where testing is difficult. We're looking for a needle in a haystack. So is Sedibeng really, really have very few cases, or are we just missing them because they're hiding in plain sight? Looking at the most recently now on June 1st with the decrease of the lockdown, how do we deal with these small fires that are coming up? And this involves, again, all of these things about testing. You don't know unless you test. What about isolation facilities? And again, engagement with law enforcement, et cetera. I spent a long time on this mass testing and screening, SOPs, trying to develop those, recommendations around prioritization for testing, and to have a strategy, et cetera. Working a lot with the models and the data and the kind of resource projections, which, and I'll come back to this in my reflections, but which initially were really focused on the number of oxygen points and ventilators that we'll need, and not so much on the isolation side. This, of course, goes into procurement. The 15 billion that's been allocated, and really what is that going to? What is the cost benefit? And are we getting value for money? And what is going to help us? How will this help improve our health system post-COVID? The whole issue around PPE, so the controls, the oversight of that, do we have enough? What is the quality? How is it being utilized? Projections, et cetera. There's been a lot of interest. I haven't gotten into this very much, but around what is the role of traditional healers, and what about complementary medicine? And at this point, maybe also I'll just go down here that issues of palliative care, and what are the ethics of non-intervention, and how can we kind of perhaps link these two to provide comfort to people? The research, et cetera, a lot around the data quality, data governance, the access, the flow, the use of MPLO, the design of MPLO to make it user-friendly. The PHRC has come into this, and the ongoing monitoring and evaluation. The NASREC itself, occupational health, the idea of, what are the needs of our staff to provide emotional support, practical support after people are exposed, and the decisions around closing facilities. What are the criteria for referral? What are the pathways for referral? So that's something we've been working on. We've also initiated M&M rounds every week. So these are with, there's been a public-private facility engagement around this, and we've actually had some very deep, interesting conversations around the deaths with the people looking after the fatalities from COVID-19. And once a month with that, we're going to have an open public forum to share these learnings from the management of those cases. Lots of issues around how do you communicate science with the public and how do you communicate with the healthcare workforce. Lots of debates around the usage of cloth masks. I'm involved in actually most, the death rates that we're capturing are the deaths inside hospitals from COVID-19. And not only from inside hospitals, but mostly in ICU settings. So I'm very interested, and we are very interested in the deaths occurring at home, outside hospitals, or family members who have been brought to CHCs or clinics post-death. We've had the unfortunate but necessary situation to look at mass graves, to look at voluntary autopsies and swabbing post-death, and some of the ethical issues around that. The public-private interface, I've raised that. What is the impact from all of the PHC essential services cutbacks? So trauma, influenza, maternal child health, et cetera. And the whole kind of PHC infrastructure. We've looked at closed institutions, nursing homes, as well as correctional services, also mental health care facilities, and the issue of Lindela and migrant health has come up. And then stakeholder engagement, for example, around data with the GCRO, the Gauteng Center Regional Observatory. So there's many other issues, but these are kind of the ones that have taken out the most time and with the most intensity. So in kind of thinking what I've been doing for the past 8 or 9 weeks or so since this started, this is a very political space. It's politicized, but there's also itself, the whole, I think, command center. We've seen this on a national level, perhaps thankfully less so on a provincial level, but it is definitely a political space. And whenever there's politics, there's power. So power, it's forced me to reflect in a way about power dynamics, my own power in this situation, the power of the clinicians, where is family medicine and primary care in all of this. I also observed these long-standing, decades-long relationships between people there that has to do with both their age. It tends to be an older group, although there are some young, dynamic people, managers coming up, and it's nice to see that. It's about status and hierarchy and the codes, because there's codes of conduct. The first day when I questioned the whole testing, the inadequacy of testing, I was told, Prof, it's okay, this is your first meeting here. You don't know, but these kinds of discussions are beyond this room. You're talking to the technocrats, so we can't decide whether we should actually have funds that are deployed for to engage private testing labs, because I was suggesting that under the Disaster Management Act, we can, I won't say commandeer, but we can engage the private sector to support the testing as NHLS was ramping up. The other codes are, yes, about relational codes and kind of nonverbal codes that people speak in. It's a very exhausting and frustrating, it can be a very exhausting and frustrating day. It's a very long day. People are there at 8. Sometimes we don't leave until past 7. It's 7 days a week. you know, Sunday through Sunday. And so there's a lot of information. People are feeling, I think, very exhausted from information overload. It's not been within people's normal routine, I think, to look at numbers, and the numeracy issues are very real. I think there is some compassion fatigue, so tempers sometimes flare. There's conflict at times. And in all of this, you know, I wonder, you know, how are decisions getting made? And sometimes, you know, we would have spent the whole day deciding something, and then at the end of the day, it gets turned on its head, or something different is actually the final decision. And that also contributes, I think, to the sense that, you know, you've put in all this work, you've stayed up till 2, 3 o'clock in the morning trying to do something, and then ultimately the decision happens in a very different way. I think, you know, these in a way go together. I think information is power, so it's very important for me, at any rate. It has been very important, and I want to say really how appreciative I am to have the connection with you on the ground, because it is a reality check. And by being on the different governance groups, not only in Gauteng district, but also with colleagues in Tshwane, because I'm representing them in the war room, as well as Sedibeng, Westrand, Ekurhuleni, and of course yourselves, that it really helps to triangulate, you know, the kind of information that's coming through from the war room, because I can say, hang on a minute, that's actually not what it is in the ground. And I've asked your permission, but oftentimes I've been able to forward WhatsApp messages to the right place that I hope has made a difference. So those were my reflections late last night. These are my morning reflections, which I think are a little bit more positive. And I think what I've been able to contribute, really, the success story, is that, you know, some conceptual paradigms and really big concepts. So in other words, that kind of holding up the mirror saying, you know, hang on, what are we really doing here in this war room? And I think, you know, over these past 8 weeks, you know, it's a very big bureaucratic apparatus. So it's difficult, but really to shift the focus away from, this is one of these conceptual paradigms, is to shift the focus away from hospice-centric approaches. And really this has got to be dealt with, you know, at community level. We have got to communicate and engage with community. So, you know, when I stand up now, people, I think, feel that I'm a broken record. And I think with this repetition, however, I think there has been some kind of shift. And of course, this goes along with the prioritization of resources, because if you think that the problem, you're going to save people's lives by putting them into ICU and hooking them up onto a ventilator, well then, you know, I think that's a problem, because your resources will all go there. But if you think, you know, that it's at community level, you know, then we'll address issues of sanitation, of water, of food, the issues around housing and how people can self-isolate or not, and then what do you need to do in terms of solitary isolation. And I've also been very big on addressing calling out wasteful expenditures, on ineffective PPEs, getting quality people into the warehouse. This question of sanitizers, did they scope or spec the correct sanitizer, and actually saving, you know, a huge amount of sanitizers, because just simply explaining the difference between ethanol and isopropyl alcohol in terms of the contents. These fogging contracts are really, you know, were completely unnecessary. So what is the science? So bringing, I think, science into all of this. And then just encouraging reflexivity and common purpose in the war room, you know, and that it's really where, you know, the common purpose is the SARS-CoV-2 virus and not each other. So really, I thought we could have a discussion. These are the 3 broad themes that Michelle distilled, probably about the 8-10 questions at the beginning. And maybe it's time now, besides, you know, what I've been monitoring and in communication with you, to really hear more of the stuff that, that you have been doing and how that relates. And I hope I've given you an overview of what's been happening in the command center. How can we improve our communication channels, and how can you assist us, you know, and vice versa. So I'm ready to.
Thank you very much, Laurel.
Yeah.
Appreciate you spending the time and providing us that insight. I hope that people have been able to get a better sense of what's going on at the top. Perhaps you know, a short reflection on my side, and I think we've had one question, and I'll come to that question shortly. Is you've talked about procurement issues and community testing issues. I'm just wondering about why we seem to be struggling on the ground, as you've noted in our WhatsApp conversation, the Joburg Clinical Governance Group, that that in fact we don't feel like anything's changed at the bottom.
Yeah.
And yet we've been voicing this concern for almost, if not more than a month, and in which you've been able to you know, hear the conversation repeatedly. What is your response to the fact that we've said simple things like paint are just not available at facility level, and it's been known, and we've had to go to the community to get donations, and that's been the only way to get it right? That's the one. The second thing is that we've talked about the wastefulness of the community testing, and that, you know, at primary care there needs to be testing, and the conversation has been again very live about the fact that in primary health care that is not there, and we've been battling, but we've not felt at all that anything from Gauteng is coming forth, despite the conversation being very evident at the top.
Okay, so let me take that in kind of two ways. Let me, so as I said, like my first input at the command center was around testing. You know, you know, do we have a testing strategy? How are we going to deploy this very scarce resource? Can we expand? Who's going to be the target? What do we do with a positive test? But that's not actually, I think, what you're asking, although it's part of it in terms of getting access to swabs. I think the community testing question, let me start there, is very interesting. And I you know, and I think that it, you know, in kind of observing what's happening and why they go to shopping malls and why you know, this kind of looking for needles in a haystack, and taxi ranks and things like that. It's actually, they view it as a way of community engagement around COVID. So I think that that's the political piece of this, that if the healthcare workforce is seen to be out and doing something and visible, you know, in these spaces, I think it, you know, it was seen as an effort to educate people, you know, about COVID-19, to hopefully have some input around social distancing, to encourage people to wear cloth masks. And also, interestingly, more and more, it became about other services that could be provided at the same time. So HIV,
so it was a very
testing,
diffuse political strategy that didn't seem to have any science behind it, simply a political design. Okay,
well,
that's
not
fine,
simply,
because I think,
not
well,
simply,
generally,
but you know, because I do think that in the absence of some of these or the easy access at clinic level, I think they felt that it was also compensatory in some way, you know, to be able to provide those services to healthy people, otherwise healthy people, blood pressure, diabetes,
But
yeah,
considering the
etc.
capacity, I mean, I hope that it was
Shabir,
voiced.
you asked
Yeah.
me for an explanation,
No,
and
no,
that's
sure.
kind of
I'm not
my,
going
yeah,
further. I'm moving on.
yeah.
The question is that
And
at
then
the,
the procurement, sorry, can I just say the
yes,
procurement?
yes, I
I
want to
think
ask
that,
about that.
yeah, so that needs to actually go through your own districts, because there are funds for that at district level. And they can count that because they are supposed to take some of their budget, and not all of the money is coming from province. So, we can talk about that, and maybe
Well,
have
I think
have a,
that's the question, is that we've been talking, and I think that's the challenge everyone feels on the ground, is how do we get action? And one of the questions here is from Lynn, where she's asked the question about, I think you can see it as well, that we need
no,
a stream of work, but let me read it out to you. It's basically our biggest concern is that we need a stream of work which is only focused on health facility readiness from primary care through to hospital care. Each facility needs to be technically supported and signed off. Perhaps I can just say it simply. We've been having a plan in Joburg that's been signed off by the chief director. We've then modified the plan based on work from Tom Boyles and Lynn Wilkinson. And we've been asking, why isn't this being signed off at a provincial level? And I mean, had some discussion briefly with us in Joburg about the details, but we've yet to see of any similar process. In fact, Yanni Hugo came to me about a month ago saying, can we not have people coming through to Joburg to see what's happening from other districts? But it somehow never panned out. So can we have an understanding of why there isn't a plan, which shouldn't be a difficult thing, but why is there not a plan for Gauteng on a similar basis?
okay, I'm not, okay, why no, okay, so we'll
Yeah,
have
I mean,
to,
is there a
I
plan
mean,
for
I mean,
primary
what
health
do you
care
feel?
that we can see on
There
on
is,
paper?
there's the health catchment area. So that's what's
Okay.
supposed to be happening, is the health catchment area model, where family physicians are responsible for that particular area. So that has been presented to the war room,
Okay.
and that's, beyond COVID. So I'm not sure I understand
Well,
the
I'm
idea
asking
of
the question.
plan.
Yeah, I think you're saying that the health catchment area, that's actually about family physicians being responsible for areas. I mean, that also been talked of. Perhaps you can briefly tell us later about, after I've taken some other questions about how that's gone on. But I'm specifically referring to a COVID readiness response from each facility. I mean, what we've done in Joburg, I'm sure you're familiar with. That is a very detailed plan on how
Yeah.
each facility ought to be responding. So we are functioning with the chief director who signed it off, but with no real district support and no provincial apparent agreement that that is what should be happening in primary care. I mean, there are crowds of people just ganging up on fronts of services. There is no physical distancing. There's no evident triage. There's no common plan for that. So that's the
So
question
what
I'm
are the
raising. But
solutions?
nonetheless, if
So
you haven't got
Shabir,
it, it's fine.
yeah,
I'd like
no,
to move to other questions.
okay, but I do want to respond to that, because I mean, I
Sure.
think that you're there. I think that plan has been approved for all PHC facilities. So in Ekurhuleni, they're doing the same thing with the triage, or attempting. So what you're describing, so I wouldn't say that there's no plan.
But
I would
we
say
got a
that
copy of that plan. Is that a copy available? Is that something written?
it's not something written, I think, right now,
Okay.
but that's what the district, that's what the district directors are meant to be doing. But I think if you're having if you're running up against these challenges, and to me it sounds like there's security issues, there's queue monitoring issues, there could be personnel. So I mean, I think if the solutions can come with that in terms of concrete things that you need, that can be escalated, and it should be
Well,
escalated.
Laurel,
If you think that the solutions are at the command center.
well, let me just briefly say, and I don't want to be sort of spewing problem. We're talking about a solution that seems to be ignored. We've actually, in the clinical governance group, which you've been part of, have known about the Joburg plan that's been available and put out there with repeated revisions based on what's happening on the ground. And I think that's a plan. It's in place. It's there. We're using it. We've also circulated the fact that there is a clear need, which is not met, which is a list of equipment, simple things like tape, hazard tape, masking tape, paint, and a bundle of other little equipment like oximeters, etc. We've actually been putting this to the managers, have had no response at all. In that clinical governance group, as I said, you've been very aware of it, and you've been taking some of the information forward. But I think we're feeling like, it's a one-way street, and I appreciate you responding by having this meeting, and I hope you don't think we've been attacking. We're just feeling very frustrated. So let me stop there because I think other people have asked questions.
Okay, can I just respond, because I have to tell you, the paint and the tape, I have not escalated to the war room. So I think this is an issue of all of the frustration that you're feeling is the issue, the decision to have placed chief directors in the war room rather than leaving them in the districts. Okay, because this is not something that at this level, I mean, that is actually would be dealt with in the war room. So that this is your solution isn't there. And now that I know about it, I can address it through a different channel. But I must say that this kind of frustration around this, I mean, I knew that there was a tent issue. I took the tent issue, but the paint and the tape I wasn't aware of. And the list of equipment, oximeters, that kind of thing, let's discuss that. PPE, I took, but okay, thank you.
Not a problem. We will submit a list, the plan and the list of requirements related to that plan. And we will try and understand what's going on in other districts, and we will submit that to you and copy to other people. But we will actually hope that you'll provide us a response in terms of how that goes forward. So let me just go to some other questions. And I think let me just go to, and I think I'll come to some other questions I have, but I think
okay, thanks, Lynn. I just wanted to say thanks, Lynn, for that, because I think it's
Lynn asked some other questions, but I think that we have covered some others as well, covered them. I think Mimi Jordan asks, can staff not be tested when needed? For example, MRC, in order to get fast results. In other words, how do we get staff fast-tracked in testing? Is that
great question?
I know. Go ahead, and perhaps we can respond to that.
That's a great question. Thank you very much. Because again, there was a decision to test all 77,000 healthcare workers, and you'll have to remember that most of these 77,000 people are represented by organized labor, by unions, and so and there was a great deal of fear coming from other parts of the world, watching doctors, nurses get sick, and tragically, many of them dying. And because we have an older healthcare workforce here, nurses especially, I think that the province was trying to be responsive to that, and so they made this decision. Unfortunately, at the beginning, at any rate, it was still competing with the challenges around testing for swabs, for PPE, for personnel, for turnaround times, for reagents, to do PCR, which is the only definitive diagnostic test for COVID, that we finally got them taken out of the NHLS stream. So now all healthcare workers will still be tested, even if not a PUI, in other words, if completely asymptomatic, but via private laboratories. So they will not be competing with inpatients or contacts or PUIs for testing. So that's
submission of the cases. In other words, is the NHLS still taking those samples away from us?
Yeah, they are. So in other words, the person needs to be referred. So this is one of the communication.
When you say just clarify the referral,
So that needs to be communicated through the occupational health work stream. So there needs to be a circular that actually goes out that explains this, but healthcare workers should not be tested through the NHLS system. There's a contract with a private laboratory. so let me, so the
Please forward
circular,
that to me.
the circular on
And
occupational health.
yeah, if you can send it to us, and then we can actually
testing,
touch base with the occupational health person in the district
to clarify
say,
processes.
tell us exactly what that means on the ground.
Great,
Okay,
thank you.
that's fine. If you can just send that to us, we could do that. Then there's, I think that's covered as well. I think the question would be also community engagement. How is that happening at the moment, particularly where people are staying away from clinics, head counts are dropping, and this is affecting general healthcare. So is there a clear plan or way to deal with it? In fact, I yesterday in Shawelo, I asked the person at the gate, told me they close at 11. I said, why? And it is something that I said this should not be happening, and yet it's still happening. So how are we going to be able to deal with this problem?
So, again, I think, I don't want to lay blame, but on the other hand, I think that, I think that there were reasons probably, and there was no engagement. I can say that around the circulars that went out to define what constituted essential services for primary health care, because almost all of primary health care, should be seen as essential services. So the restrictions on that to begin with was a problem. I know that the thinking was to be able to separate COVID from non-COVID, or respiratory versus non-respiratory, but I think in a way we're suffering, well, I know we're suffering from those consequences. But, the response on the ground, the facility closure or closing earlier, is really not acceptable. But I mean, I have not heard about that. I don't think that's been taken up as an issue in the war room. The community engagement, it's again, that's a really good question. And I think that there were attempts at communications or communicating. And I think part of the idea to go on this kind of outreach at shopping malls and taxi ranks, et cetera, was really to re-engage the community, as I mentioned to you. But I think that people are afraid. There's been a lot written about trust in this, in this whole pandemic across the country. And like trust is very hard to build and very easy to lose. And so I think that's really what we're dealing with, at public level, is how now do we rebuild trust, having in a way, prevented access to these services, now saying to people to, it's safe, it's okay for you to come back. And yet at the same time, rocking up and saying, well, no, I'm sorry, we're closed at 11 o'clock. So, so these are things, though, I'm sorry, that cannot necessarily be dealt with in the command center. I mean, because what will happen in the command center is that people will get called out about it. And ultimately, it's up to the district to fix that. And so what this is also doing, and I've written about this, is that it's laying bare the fault lines of dysfunctionality, of either good functionality or dysfunctionality. And unfortunately, it's the fault lines of how things don't work, and it's being exacerbated. So I think we really need ways, and I would welcome ways from among yourselves, and it has to be dealt with at district level. Your chief director, who's ultimately responsible, has to say, this is completely unacceptable. I mean, Dr. Sanabe, as the head of the occupational health stream, can go in and say, well, look, these are the criteria to close down shut down a facility. I've heard, for example, in a Kuruleni, that one nurse tests positive, while she was on leave, and then they decided to shut down the clinic for the MOU for the next 3-4 days.
Okay. Thank you. Laurel, I just want to keep time. And then also there's some other questions that I haven't seen, and if I can just quickly pick them up.
Yes.
The
Maybe
one
give me a
is,
few of them. Yeah.
Yeah, they're a bit long, so I'm going to just cut it a little bit. Yeah, the one, I'll put together the related ones. I think there's two related. Anna Tipe asks from Sedibang that she's struggling with private labs that are limited in their testing and that don't have the skill, it seems. Testing. Yeah, sorry, I'm trying to understand this question. She said she had to test at a private clinic. The two labs had access in the very district, limited I think that they went through testing of staff who didn't. I think that maybe the problem is, I'm not sure whether it's the private or the public, but the staff testing skills seem to be poor. I'm not sure whether that's also the question of, is the private facilities actually adequate enough when you talk about the staff testing going through private labs. So perhaps you can just, I'm not sure that you can
I don't
respond
know,
to that.
Shabir.
Yeah, it seems a difficult question.
But maybe they can reach out. The colleague is welcome to reach out. You can put us in touch, Shabir, perhaps, and I'll deal with that.
If you don't mind, just put your
offline.
email. Yeah, just put your email into the chat
Yeah,
group,
let
and
me
I think
do
people
that.
can then speak to you directly.
I'll have to do it on. I'm not seeing any of the chat.
If you hover on your screen, you'll see a chat at the bottom, and you'll see the bar come up, and then chat is on the list.
I think Shabir, when I'm screen sharing, it doesn't work.
Yeah, if you take
There
off
it
the
is.
screen sharing, yeah, there it is. Okay, not a problem. Otherwise, I'll put it on. I think the question of quarantine relative of the turnaround times being 21 and 14
Horrible.
days. How are we going to manage quarantine? I think yeah.
They mean isolation.
I think isolation actually, but
isolation. Yeah,
exactly.
It's isolation and not quarantine. Quarantine are asymptomatic.
Sure.
Okay. So so this has been thank you for that question. It's been a major preoccupation of mine, and that's I think why we're not actually able to stem the spread. And so I don't have a good answer for that, although I've been lobbying for more isolation sites, and NASREC is opening up, but that's again, that will not be for PUIs and waiting for results. And the prioritization for testing has actually now gone to people because it's going to determine treatment in hospitals. So it's actually for NHLS at any rate, NHLS is prioritizing sick hospitalized patients. So mild symptom PUIs in the community, those tests are taking between 11 and 14 and sometimes longer. Like I have not had my test result back, and I did it, let's see, 16, 17 days ago.
But
just as a baseline.
Is there any plan to change that?
So the plans are political. I mean, again, it's there are not enough.
Are you providing the science to it?
Absolutely. So the issue is that it's a shortage. It's a global shortage of reagents.
Okay.
So it's really the issue of what it takes to run the PCRs. So they can't make the reagents, and so unless India
I understand the reagents, but isn't there prioritizing of sorts going on?
Yeah, there is, and that's what I'm saying. So the prioritization now is for sick inpatients to get a status. Yes.
So is that the only priority? What about PHC facilities? Should we be routine testing, or should we be narrowing our scope of testing?
Not at the moment. The way that it's been happening is, and it's not great, and again, I'd be open to suggestions, but the prioritization is firstly very ill patients in hospital. So it's kind of, the test then becomes life-saving. Then after that, it's contacts of people who, it's contacts of all those people in hospital, and it's contacts of people who test positive for COVID, including the healthcare workforce. Okay. So because it's really prioritizing the workforce. So kind of people with one of the PUI symptoms, et cetera, that they're further down the list.
Yeah. So let's, I think that's a clear problem, is that we don't have a plan of that. We are actually testing right now. So I think there are a number of questions that are emerging, and I think this consultation has been useful. My suggestion, Laurel, is that, and I'll just point out some of the little questions, but we won't be able to take them. One is the, progress on the family physician appointment in the catchment area. There's no evidence of what's happening. I think the question of GPs, they feel very isolated, and what procedures are in place. We've had a conversation about it briefly, but, and I suggest we just tab them. We won't be able to go through them. And then I think the, quarantine for healthcare workers, when we have exposure problems, how do we deal with that? So there seem to be a number of things that are completely difficult to manage, and that we are literally battling on our own. So what we're going to suggest is we would like to facilitate a meeting of the, of yourself and other key stakeholders from the district and perhaps other districts interested, to look at how we can have a, a way to engage more widely on some of these and have a little bit of a longer discussion with key stakeholders. Would that be acceptable, Laurel?
I think that would be great. And I actually think that if you would like to organize yourselves, and perhaps even give a presentation to the War Room, on some of these issues. And, I think that would be also, we could organize an invitation. And then you can, maybe, some of you can come, you'd be welcome. And, in the next week or two, to come and really talk about some of these, what the experience is like on the ground. But in the meantime, I'm on the list. People who didn't get their questions answered or want to engage further, please contact me via email.
Yeah.
Okay, I hope this was helpful.
Thank you very much. Really appreciate this. And I think that our hope is that we can get some better relationships going. And as we've talked of now, let's look at a meeting with the key stakeholders. This being a public open meeting, I think if you have any questions or issues to raise, just forward them to me, or problems to raise, and I will include them in our process as we're going along. You've got Laurel's as well. And hopefully we can just get a sense of the issues to take forward and engage in a meeting of key stakeholders and look to presenting that. I think there are a number of issues, Laurel. We've not had a clinical governance meeting that has engaged people on the ground. And I think hopefully we can pick up more than just COVID, exactly where are we going with the clinical governance. So thank you very much,
Laurel.
You're
welcome. Pleasure.
We'll plan it from there. Thank you very much.
All right.
Thank you all for participating. Go well, enjoy, and be safe for the rest of the day. Bye-bye.
Okay. Thank you. Bye.
Bye-bye. Thanks, Laurel.
Bye.